I want drugs. I hear it every day. Not in my practice because I don't do a pain practice, but people come up to me. They say, what drug do you recommend for my back pain? Do I want narcotics? I want something now. Turn the pain off, doc.
So, you've heard it a dozen times already, this multimodal, multifactorial process. I'll tell you one of the reasons for that was when Joe was just speaking, I talk to patients all the time. Hey, we don't have one single drug that will give you 100% efficacy. And therefore, as clinicians, we're forced into this multimodal approach. Right? So when patients come up and say, hey, what drug can I take for my back pain? I usually say, hey, there's not one single drug that's effective for all kinds of pain, and it varies from patient to patient, which is why we need to go through these multi-drug trials.
But that is so unsatisfying to patients.
I know, but part of it is that pain is perception, and that's why we do not have one golden bullet. What we're doing now, though, is we're a little smarter, and we're not just blanketly treating back pain. I think we are addressing it based on severity upon initial presentation, and then particularly with moderate to severe chronic low back pain, we're making sure that whether or not there is an neuropathic component to that, and we're trying to become more mechanistic driven. Chris?
I would say it depends on who's presenting with the low back pain. A 25-year-old with no MRI findings, no X-ray findings that has low back pain is different than somebody who is 68 years old with severe spinal stenosis, and I think the approaches can be different on that.
But I'll tell you this, I did a study with a device, and because of the nature of this device, we really could not, for chronic low back pain, we really couldn't have a sham. And what we found is that having the patient come to the clinic for 20 visits within 6 weeks, we found a tremendous, like almost 86% reduction in their pain. Now, was this placebo mediated? I'm not sure. I think part of it is, how often if any of you got hurt, could you really give me 5 days a week for the first 2 weeks, 3 days a week for the next 2, and then 2 days a week for the following 2 to come see me for an hour? That just doesn't happen,
They want
right?
a pill. They want a pill.
They want a pill. They want a quick fix, and that's part, again, to this idea of coping strategies. It also is very different than other chronic disease management states. When you have chronic pain, you don't really get a chronic pain educator like you would with diabetes, right? You have diabetes, the moment you have that diagnosis, someone's going to come, and there's appropriate funding towards coming to educate you how to eat properly, how to monitor your glucose, how to do these other things. That's missing. That's where it comes back to healthcare policy.
And with this, I'm just going to put this here, and I'm going to paraphrase what you said and echo it, because I think it's fair to say you'd all agree, there has not been a recognition of chronic pain as a syndrome on the order of magnitude of diabetes, which merits the same kind of national attention. No educator, things like that.
Right. Instead, we have a lot of education on the potential, let's say, negative side of treating patients with certain types of medications.
And hold that thought, because that's just where we're going. We're going to talk about